Hello, I'm Tanushree Rao, and today I want to talk about hysteroscopic resection of the niche. So we've compared in this video two energy devices. One is using bipolar resectoscope and the other one is the monopolar resectoscope, and then you can decide for yourself which one gives a better outcome. So this is a lady who has completed her family, and usually these women have this common symptom which is post-menstrual spotting. So all this blood gets collected in the niche that you just saw over there. So this is the cervical os, and just beyond that is like a dome-shaped structure, which is the niche, and then once you go beyond that, you get to the uterine cavity along with the two osteas that are opening. So this blood gets collected in the niche, and because of which they have this classic post menstrual spotting. So I've used a bipolar resectoscope. In the hospital that I did this procedure, they actually didn't have a bipolar resectoscope, and the nurse suggested that I use the TURP or the TURP resectoscope. So this is something that the urologists use regularly just to take a bit of the prostate out. And this is my golden advice: always trust your nurse. She actually knows best. She will give you what you need and not what you ask for. So it's beautiful that I work with such nurses who are really experienced and give a lot of input into my work as well. So I'm always grateful for them. So she handed me this resection. She was like, "You try this and see how you go." And I did, and you can see as well. So the advantage of bipolar resectoscope is the current runs between the two blades in itself, does not pass through the patient to form a circuit. So the circuit is just between the two blades of the resectoscope, and then that feeds back through the wire. So the goal of this procedure is to actually level out the so how we mentioned it's like a dome, like a U-shaped dome, inverted U-shaped dome. So you have to level out one part of it, so that even if blood gets collected, it doesn't stay there. It just gets flown out, and that's exactly what we're doing. We're trying to resect it out. The reason why I've chosen hysteroscopic resection for this and not laparoscopic repair is because she's actually completed a family. Fertility was not a concern, and her main issue was abnormal bleeding, which included both heavy bleeding along with the postmenstrual spotting. And the way we investigated this was we got an ultrasound, saline sonography, and sure enough, a niche was demonstrated with the dimensions that we can see over here. Now I've gone ahead and done a radiofrequency ablation for her as well. As you can see, these the burnt bits of the endometrium, and the niche is also burnt a little bit, ensuring that she actually doesn't bleed. And as another form of protection, I've gone ahead and put in a Mirena as well. So this is case 2, where I've used a monopolar resectoscope. This is something that's easily available in our gynae trolley as well. So over here, similar symptoms, post-menstrual spotting along with heavy bleeding, and which is why we're choosing a hysteroscopic mode. And once we go inside, you will see at times there are certain glands on top of the niche as well, and those can contribute at times to abnormal bleeding and postmenstrual spotting as well. So it's really important to get all of this along with leveling it out. It also depends on the thickness of the niche that they see. Just be wary when the niche is really thin. We need to be a bit careful. So these are called practice cuts. Okay, so even before you activate the energy, I do a lot of practice cuts to make sure the flow is smooth and there's no barrier for it to retract and move forward. I've used monopolar energy over here, and that monopolar energy is quite concentrated and precise. It'll give you clean, sharp cuts. But what's the downside? The downside is that because of the concentration, it has a greater power of penetration as well. So the lateral thermal spread is a bit more than bipolar, which is why bipolar is a bit more safer. But you can see that the cuts are really neat and precise, which is why some people prefer the monopolar over the bipolar. over here, you can see that I've taken few cuts already, but I'm trying to really level this out. I'm confident over here because I know that the niche is not quite thin, so I am confident to take further superficial cuts in order to level it out with the niche that's there. At times, you will see that tissue extraction is the problem with resectoscopes when compared to the MyoSure or the tissue retrieval system. It's the tissue that sometimes gets stuck, so you just need to move forward and backwards. Sometimes a short burst of your foot pedal as well will just free it up, or just use some really good force to just as Taylor Swift has said, shake it off. Okay, so we go ahead and we reassess. We have a look again. I think I'm thinking now, do I need to do this? So you can see my hesitation cuts over here. Do I need to level it out a bit further? So I think I felt at that point, yes, I think it can be, it can do with a bit more leveling, which is why I've gone ahead and leveled it out a bit more. Now, again, this is exactly what we spoke about. The cuts delivered, then get the tissue a bit stuck to the monopolar hook. So you just, shake it off. And once again, reassessing, making sure you can see that the dome is really leveled out. Now you don't even have to go inside and then visualize the dome through the stenotic os. At one go, when you're at the internal os, you can see both the niche and the leveled out cervix that's there. So this, I think, is a good resection where we've taken adequate amount of niche. Now, some of us also go beyond this and take the other part of the U and level it out as well. I don't do it. This is how I do my niche resection. And you can see that I've gone ahead and ablated it. We use something called NovaSure over here, which is nothing but radio frequency ablation, and burns the lining of the womb. So once that's done, we stop the procedure. It's done. I've put Mirena for both of them. I always put that because if there is an element of adenomyosis, and also after ablation, you need to make sure that they have good contraception. So either you do salpingectomy or you just stick a Mirena in. Serves both purposes. Prevents abnormal bleeding, and then reduces the heavy flow, protects against cancer, protects against endometriosis and adenomyosis. I'm a big fan of it, so I usually do encourage women to put it in, and you help them transition into menopause and then take it out after that. All right, thank you for your patient listening and watching. I will be back with more videos. Stay tuned.